layer-specific microvascular details. So in contrast to the normal OCT which Biju spoke to us, it not only detects the intensity of the reflected light, but sequential temporal changes in reflection by moving particles are also detected, giving us altogether another perspective. So it uses the laser light reflectance on the surface of moving RBCs to give us accurate depiction of the blood vessels. So repeated B scans, maybe up till 1 lakh B scans per second, is basically performed through the area of interest. And stationary tissues show minimal or no change to the signal, whereas dynamic tissues like flowing blood will show the changes, and these are depicted, and this is layered on top of the normal structural OCT. So not only does the structural OCT, which we already know for the last 20 years we get, along with that we get the flow as well. So this is how the detected normal A scan images and the OCT A signals, which will produce flow B scans, which are a little different from this. So these are the commercially available OCT angiography machines. And let us go a little bit into the because we are not very kept about the OCT angiography, unlike the OCT which all of us have seen over the last 20 years. So I'll just talk a little bit of that and then go into the clinical examples. So there are some reference planes like the ILM, the outer boundary of the inner plexiform layer, outer boundary of the outer plexiform layer, the retinal pigment epithelium and the Brooks membrane, and the layers are found out in between these. These automated algorithms actually segment them between these layers, and so that we get layer by layer structure. So OCT interpretation, as I said, is based on the ability to image the flow. So we can pick up abnormal presence of flow, absence of flow, abnormality in flow geometry as well. And retinal vascular disorders, both in the superficial and the deep slabs, can be done. Choroidal neovascular membrane in the avascular and the ORCC slab. There are a lot of artifacts here, and we compare with structural OCT always to diagnose active leakage. So these are different slabs, right from the vitreous, the superficial vascular complex, deep vascular complex, outer retina, choriocapillaries, and the deeper choroid. So these are the different slabs which can be there. So let's look at them one by one. One is a vitreoretinal interface, where actually it's on top of the retina. So any neovascularization which has crossed the ILM and gone into the vitreous can be picked up there. Then this is the capillary plexus, the superficial, the middle, and the deep. And the superficial capillary plexus have the nerve fiber layer vascular plexus as well as the superficial vascular plexus, which is quite superficial. Then we go deeper into the deeper capillary plexus, where most of the vascular diseases make havoc. The intermediate and the deep are covered here. And then we have the outer retina, which includes the photoreceptors as well as the type 2 choroidal neovascular membranes, which move on top of the RP into the outer retina. And then we have the choriocapillaries, in which the choroidal neovascular membranes are there. And finally the deeper choroid, in which maybe the polyps and all are there. So how to look at it? So first of all, in a clinical picture, you have to find out your area of interest, and then look at ANFAS OCT image on those areas, and then look at those segmentation lines where we are segmenting, and look at the B scan and the flow overlay. And actually you have to structural OCT and the fundus picture and the OCT angiography needs to be overlaid on top of each other to look at what is happening. And this, if you repeat over a monthly period, you know how each particular area is behaving, and that is why it is very useful in follow-up angiographies. So some terminologies that you will hear. One is segmentation. Segmentation, I told you, into different layers, and each of these layers you can see the ANFAS OCT images as well. So that is how we get the slices, and these are different slices, right from top to bottom. There are different slices which I explained to you about. And ANFAS image is a transverse slab orientation, which gives an impression as though we are peeling off that part of the retina and looking directly inside. Then we have motion correction technology. I will not go into this. Avascular retina, the right central, this foveal avascular zone is a avascular retina which can show changes. Non-perfusion areas are in retinal vascular blocks and conditions like that, vasculitis. You can see neovascularizations, artifacts. There are lots of artifacts, including motion artifacts, stretch artifact, doubling artifact, displacement, masking, blink, unmasking. So a lot of artifacts are there here, unlike the fluorescent angiography or the OCT. So we have to take into consideration all these artifacts and then move out into what is happening. So OCT angiography versus fluorescent, this does not require intravenous injection. It can be acquired in a few seconds. It doesn't cause any problem. Non-invasive, no nausea. Follow-up scans every month we can do. But the problems are it cannot evaluate leakage. It detects abnormalities by methods both based on depth, vascular pattern, etc. Since there is no dye leakage, there is a little bit of a problem. But capillary dropout as well as neovascularization can be done. This is just a photograph which shows the difference between fluorescent as well as OCT angiography. But in fluorescent, we pick up wide field. In OCT angiography also, wide field machines are available currently, but they are too expensive. Alright. So now let us move into some disease conditions like diabetic retinopathy. In a condition in which this OCT is completely normal, in which we would say, okay, there is no significant change. But you can see that even in normal looking eyes of diabetic retinopathy, you can see enlargement of the FAZ or capillary tortuosity or capillary lumens. Like for example, again, this is a completely normal looking OCT scan. But OCT angiography tells us increase in the size of the FAZ and small areas of ischemia, vascular fan is irregular, presence of microaneurysms, vascular roots, etc. So all these are picked up on an OCT angiography, which gives us an insight about the progression of diabetic retinopathy even in the presence of a structurally normal OCT scan. Now, so these are some of the features which I explained before. So these are, FAZ features which are increasing. So you can see the FAZ is increasing, or you can see aberrant congenital macular vessels. These are microaneurysms. Compared to fluorescent, OCT can detect most microaneurysms. This is because some of the microaneurysms have slower flow. So if the flow is slower, or if it is a almost healing microaneurysm, then probably the microaneurysm cannot be picked up here. Neovascularization elsewhere, especially if it is the posterior pole, we can have up to 12 into 12 or 16 into 16 slabs in the newer OCT machines, which we also have. So, but we do not have a wide field peripheral OCT angiography. That is a limitation here. So, NV in the posterior pole can definitely be picked up by an OCT angiography, but not in the periphery. Neovascularization of disc can be beautifully seen. Now, the problem with neovascularization is sometimes the neovascularization will persist even after laser therapy. And in a fluorescent, you can see the reduction in the leakage, which gives us an indication that laser is adequate or not optimal, or your decision is based on that. But here you cannot use that. Now, retinal vascular diseases like retinal vein and retinal artery occlusions, the superficial and the deep slabs gives us very, very good idea. So it enables the detection of neovascularization as well as ischemia. So limitations is restricted field of view because you cannot go right to the periphery, and it does not indicate whether the neovascularization is leaking. So here it would be a retinal vein occlusion. You can see the picture which shows that the ischemia is significant, and edema can be seen when the vessels are broadly, the distortion of the mesh of vessels. Non-perfusion areas are grayish granulated areas. So in an RVO, you can see the deep vasculature also showing these changes. Artery occlusions, superficial and deep occlusions, they are completely occluded and drop out, and sparse mesh will be there. Alright, so this is an artery occlusion. You can see the loss of capillaries in that particular region. A dry age related macular degeneration, it could be early or late. Early would have bruises, there will be a generalized reduction of coronary capillary density and dark patches. Late AMD, geographic atrophy, there will be choriocapillary loss with choroidal vessels growing into that particular area, which shows as white dots. CME, we can see abnormal dilated tortuous vessels, vascular complex under the RP or on top of the RP. So these are the different patterns of choroidal neovascular membrane based on OCT angiography. Here, unlike in a fluorescent angiography, this will slowly reduce with every month when you are photographing. If you are giving injections, you can see the reduction, and you can monitor your treatment based on an OCT angiography. So type 1 choroidal neovascular membrane is below the retinal pigment epithelium. So there will be a retinal pigment epithelium, and below that you could see the neovascularization. And type 2 would be the retinal pigment epithelium is breached and will come into the outer retinal area. And so this would be a patient example. And choroidal neovascular membrane, there is a central area of definitely neovascularization there, and you can see that after treatment there is a reduction in the size of the neovascularization, which will guide us towards treatment. So So again, another patient in whom you can see the progression after treatment with each visit. Polypoidal choroidal vasculopathy, there are typical thumb sign and large tall peaked PEDs in OCTs, but here you can see the actual polyps deep inside and the polyp regression also. CSR, acute or chronic macular telangiectasia are other lesions which we can manage and monitor with OCT angiography. Some of the problems with the OCT angiography would be that its inability to show leakage, pooling and staining, and tendency for a lot of artifacts which you should take into consideration. You should see an image, you should look at it for, unlike fluorescent in which you can see the leakage immediately, or unlike an OCT in which few images can rapidly give you a pattern-based diagnosis. Here you require to spend some time, look each slab by slab, look at what was the previous OCT angiography, look at the same place to see how the the angiographic pattern has changed, and that is something which is required. So one more problem is this is automatic segmentation. When there is large changes in the macular volume or the macular edema, then automatic segmentations can provide to be a little problem which we have to use manually. So sometimes neovascular networks can be a little difficult to pick up in terms of large PED or markedly deformed macula, or if there is a lot of hemorrhages which are overlying it. So these are some aspects of OCT angiography. Hope it has made a little understanding about that. Thank you very much and happy